Hi everyone. This is Dan, one of the registrars that was working at York up until the end of February, beginning of March. I'm really, really sorry to have gone. I love my time there, and I'm just sorry I didn't get to spend more time with you all. So I asked people if they would like any teaching on any particular topics, and two things that came up that were quite linked: maxillofacial emergencies and dental radiology. So I thought I'd speak about those for you today. Sorry I didn't get to do this in person, but I hope having this video would be useful for you and you'll be able to refer back to it if needs be, because I know we don't really do a lot of dental and max fax plain film particularly, and I hope it might be interesting. So things I want to cover while we're going through this today: history of the patient, mechanism of injury, things like that, and important things we can pick out from the history. The different radiological techniques we can use, mostly plain film and CT, because we're mostly looking at bony injuries when we think about facial trauma, and also dental imaging is also X-ray based because it's very, very hard with the calcium in the teeth. And then injuries that we can get to the different parts of the face and the teeth themselves. So, first thing to think of is the mechanism of injury, not only because we want to think about the things we might expect to see on our images, but also thinking about other complications such as hematoma, vascular injuries, spinal injuries, and head injuries, so we think about brain as well. It's also important to document clearly if there are any allegations of assault. For instance, if the patient doesn't tell the A&E physician and they request an x-ray but they tell you, oh, they were kicked in the head, it's really important to write that down for sort of legal reasons. And also consider medical photography if there's an external head wound, for instance. Also, anticoagulant status is important because, people bleed. So that kind of speaks for itself. So, more interesting things now, the radiology. So when we're looking at the head, we can look at plain films, and we classically do an occipitomental view and a lateral view. We can do separate views of the mandible for the lower face. We can either do a PA mandible or we can do an orthopantomogram, which is the all-around flattened view, which is they're both useful, but each is more useful for something different. So we often do both if we want to look at the whole of the mandible, because basically the central part of the mandible in the midline gets sort of flattened on the OPG, so that's better seen with the PA mandible. But around the sides, because we're not seeing them on FAS, it's often quite difficult to appreciate them on a PA mandible. So if we're worried about mandible angle injuries, we look at an OPG. And then, of course, we've got CT for facial bones and head, and then the cone beam dental CT, which I've learned about and I found quite fascinating. So this is the classic occipitomental view. These are things that we can kind of see. So we can see the bony parts of the face, and we can all see the aerated sinuses behind them, and they give us enough contrast to actually pick out the detail within the face. This is usually taking at 15, 30 or 45 degrees, depending on what we're looking for, but I'm sure you all know much more about that than I do. When we look at the lateral face, it's very, very similar. We just do a plain orthogonal lateral, and again we can see the soft tissues, but we can also see the bone parts of the face, and because we've got aerated sinuses we get really good outlining of the bony contours, so we can look for things like fractures. Very, very intelligent people can look for pituitary expansion where the sella turcica is either expanded or eroded away. And it's also good looking for inhaled or ingested foreign bodies if they're in the upper aerodigestive tract, similar to a lateral neck if we're worried about a foreign body within the pharynx. So the mandible, as I was saying, you can kind of see here that the centre where the symphysis is, you can kind of see the bottom four teeth quite well, but because the mandible has a continuous curve where the angle and the ramus are, you don't really get quite as much detail, and that's why we often use the OPG. Whereas here you can see that actually in the centre it's slightly blurred where the image is folded over, but actually at the angles and at the periphery of the mandible you actually get really, really clear, good detail. You can see all the teeth here, you can see this patient's their bottom right wisdom tooth hasn't erupted yet, but in fact all their wisdom teeth haven't erupted yet. But you can actually tell that detail because you can see where the jawline is, you can see where the bone line is, and then you can see the crowns of the teeth as well. And you get quite good views of the inner pulp of the teeth, but I'll come on to that anatomy more later. It should be said, of course, if we usually do an OPG for either dental abscesses or mandibular trauma, but if we're thinking about if someone's got a clear fracture and we need something for surgery planning, we would do a CT. Like most surgeons nowadays will want a CT, they'll want the 3D reconstruction to actually plan their surgery with. This I've put in, it's a paediatric OPG, and I've put it in mostly because it's terrifying. Because obviously you can see that there are a lot of teeth here which you wouldn't expect, and that's purely because towards the lumen of the mouth you can see the paediatric teeth, the milk teeth, and then actually within the jawbone you've got the adult teeth which are waiting to erupt through. So if you're going to do an OPG on a child, you might see something like this, and at first it really does look quite scary. But this is not traumatic. This person hasn't been punched, they haven't had teeth that have been moved. This is just the fact that they've got teeth in their jawbone that we can't see clinically, but we can see radiologically. Okay, so dental anatomy. Quite a few people ask me about dental anatomy, and I've got to admit it made me learn it quite well, because it is confusing at first, but it's logical, so it is easy to follow after a while. So I should say in Europe and America they use a different naming system for dental anatomy, and I've got to admit I think the British one personally makes more sense because the other one's easy to get confused. So in the UK we use the Palmer notation, and basically each tooth is given a 3 character code. So the first character is the row, upper or lower, or U or L. The second character is the side, left or right, L or R. And then the third character is a number in adults from 1 to 8, because we have 8 teeth in each quadrant, or a letter in children because children have 5 milk teeth in each quadrant. So if you are wanting to describe the tooth which was on the right side of the top row and it's the second premolar, you would call it an upper right fifth, or a UR5. Whereas in children, if you wanted to describe the lower canine on the left side, that would be a lower left C, or an LLC, because that's the third tooth, and we use the letters to describe the fact that they are milk teeth for the children. The teeth can globally be divided into 2 sets. You have the central, lateral and canines at the front, and these are for biting, and sort of breaking food into smaller parts. And then the first premolar to the third molar are for chewing. So they have sort of different functions, and so we can broadly divide them into those categories. So the nomenclature for teeth is quite quite complicated, but it's one of the things that we have just had to learn, and it's been quite interesting to go through. So the teeth themselves have 5 surfaces, you can imagine, because if you think about the teeth, they're kind of basically a cube, but one of the faces of the cube is within the gum, within the jawline. So they have one side that faces away from the gum, one side that faces forward, back, left and right. So the ones that face towards the face, i.e. away from the tongue and out towards the face, are known as the facial surfaces. And for the incisors and canines, they're called the labial surfaces, sometimes because they face the lips specifically, whereas the chewing teeth are called it's called the buccal surface because they face the cheeks. So the inner surface is called the lingual surface. Again, this is split into, for the upper row, it's called the palatal surface because the inner surface of the teeth actually faces the hard palate. And on the bottom row, they're always called lingual because the mandibular teeth always face into the tongue. For the top surface, the one that's away from the jawline, it's known as the masticatory surface, which is used for mastication or chewing. So for the incisors, which are specifically for cutting, and in the canines, That's also called the incisal surface. And if you put your teeth together, you'll notice that your incisors the top row of incisors go over the bottom row, but the chewing teeth actually come together. So that surface is also known as the occlusal surface because they occlude, that gap disappears. And then the other, the sort of the forward and back surfaces of the teeth are known as mesial if they are closest to the midline, and distal if they are further from the midline. So if you're thinking of your own teeth now, the surface of the tooth that points towards your nose is mesial because the angle of the jaw goes in that way, so that will always be pointing slightly more towards the midline. And the surface of your teeth that's pointing towards your ears are the distal ones because they're always pointing away from the midline because the jaw is angled. I'm not going to lie, this is something I have to look up every time. But it's good to just sort of collect those ideas, and you might hear things like the labial surface, the buccal surface, the palatal surface, and it's you can kind of from the word work out what it means, but first time you hear it you think, what are you talking about? I have no idea. On the left here, this is a picture of sort of general tooth anatomy. This is not something you'll see all of on radiography, but you will see, as we saw earlier, that the pulp earlier on the OPG, that the pulp is actually quite visible. So on dental anatomy on radiographs, you can see the dentin has a quite slightly lower shadow than the enamel, which is quite calcium bright, and then the pulp itself is really quite hypodense, so you can really make out that neurovascular architecture. Yeah, so the enamel is made of hydroxyapatite, which is the same thing that bone is made of, which is why it looks like bone on CT and X-ray, and why it's so useful to use these techniques to image teeth. The dentin below is quite soft, and it has a neurovascular supply. It doesn't have a neurovascular bundle within it, but it has neurovascular supply. So because it's soft, it's able to sort of deform and transmit pain signals if something irritates the enamel above. And then the pulp below the dentine contains all the neurovascular bundles. So they will detect changes in heat and pressure, and that's the thing that is quite sensitive if you've got sensitive teeth. And also that's the reason why if we have ulcer tooth, it bleeds and it hurts. And it's because of this rich vascular supply that actually we're able to repair the dentine. So if there is any damage to the tooth, you are able to heal the dentine, but the enamel is laid down that bone. It's very slow, so we don't tend to repair that as we would. Like you can imagine, a fracture for a bone might take up to 2 years to heal fully, so we just don't get to that point with teeth. So next, we come on to imaging techniques. So facial bones obviously can be imaged with CT, and the beauty of CT at the moment is that we can get these really, really good 3D reconstructions, which we can show to people, and we can get really, really clear imaging of, as you can see here, the mandible and the teeth. Conventional CT, single slice, multi-slice detector CTs are very, very good for this. However, a lot of focus has moved recently to cone beam CT, and a lot of people ask me about what is cone beam CT and how does it work, because it does seem like magic, and I've got to admit it is kind of like magic. So, cone beam CT, this is really, really cool. So on the right in image B, we've got our traditional fan beam CT, which is what we're used to with single slice and multi-slice detector CT. And basically this has a gantry that rotates round in a helical fashion and takes multiple serial slices of the patient. The invention of cone beam CT, rather than using a fan, which is collimated very, very strongly in the y-axis but allowed to disperse in the x-axis, this uses an X-ray beam which is allowed to disperse in both the X and Y axis, so it creates a cone of radiation, as you can see in image A. The beauty of this is that you can get a fantastic image of a small area with one rotation, so you don't need a gantry, it just swings around like an OPG. And then you have detector elements in your detector that detect in both the X and Y direction, so they take, rather than just being a single pixel that takes a value in its defined space from the fan beam, it will take signal from the X and Y direction, so you get this really rapid image acquisition. This is of course fantastic for small parts, and like I say, it's used mostly now for dental X-ray and extremities like wrist and ankle, because of the decreased examination time, which also leads to a decrease in movement artifact, and also an increased X-ray tube efficiency. The disadvantage, of course, there must be something, is that because this beam is divergent in 2 dimensions rather than just one, there is increased scatter, and you can get coning artifacts or cone beam artifact on conventional CT. If you don't post-process these images and reconstruct them properly, you get a quite significant cone beam artifact from cone beam CT. I was reading a few papers, and actually people are going to start using this for chest CT next, which I think is quite good, particularly for people with COPD or infections that just can't hold their breath. It would be quite useful to have this sort of technology to get a really rapid diagnostic image of the chest. But obviously the chest is several times bigger than dental anatomy, so the loss of detail is the thing that's really holding that back at the moment. But hopefully as technology improves, that will improve. So if you remember the image we saw previously of the teeth from a standard multi-detector fan beam CT, we've got quite a lot of detail. We can see the enamel outline of the teeth, we can see the bones quite well. If we now come on to a cone beam dental CT, you can see that the quality of the image is fantastic. It's slightly fuzzier and blurrier, but the detail that you can actually appreciate is fantastic. You can really see the intricacy of the teeth. You can even sort of appreciate the inner trabecular architecture of the mandible on this scan as well. I think it's a really, really good scan. And so it's no surprise that the surgeons prefer this for surgical planning, because it is just so exquisitely detailed for bony architecture. Okay, so we've talked about the technology we use to obtain images. Now the next question is, what can we see and what injuries can we detect with them? So if we go next to the upper face, really the upper face is the frontal bone. It's everything sort of above the orbits. So it's the frontal bone, it's the supraorbital ridge. So the biggest thing we're going to see is fractures. Patients that have frontal bone fractures, particularly with sinus fractures, they'll often have supraorbital tenderness, there might be swelling, there might be a bruise over the area or a laceration. And if the fracture has gone through the sinus, they'll also have crepitus or surgical emphysema. They'll crackle when you press the skin, because that's the little air bubbles popping. The supraorbital nerve also travels through the supraorbital ridge, so they might have numbness in this area if the nerve's been interrupted as well. So the way that surgeons would fix fractures like this, it's quite simple. Because this is such superficial bone, you dissect down, expose the frontal bone, examine the sinus, make sure that the sinus is healthy, do a washout if there's any hint of infection, and you displace it. You fix displacement with microplate fixation. So we literally just screw panels onto the side of it and fix the bone back into place. If the anterior wall is missing or displaced and there's significant sinus damage, they can actually put in a bone graft to completely obliterate the sinus, and that gives a good cosmetic outcome as well. If the posterior wall is breached, however, they remove the posterior wall and repair the dura, and then sort of allow the swelling into the natural burr hole that's been caused by the fracture. We worry, of course, about posterior wall fractures because beyond the posterior wall it's the dura and then the brain, so we worry about tracking infection. But yeah, we can graft, we can repair them with a graft, or we can use an acrylic plate or a titanium plate or something that's sterile and that's going to be inert, so the immune system isn't going to try and fight against it too much. I've got some more gory pictures later on, but that one is a bit, you can see that it's just under the skin, so it's really simple. You open up and you fix it. So if we're thinking about the orbit, you can get an orbital blowout fracture. So an orbital blowout fracture is caused by sharp pressure to the orbit directly, which basically pushes the orbit back, and that increased force in the posterior part of the bone, pushes the globe of the eye back, and that increased force in the posterior orbit cause something's got to give, basically. So usually you fracture the orbital floor and the orbital contents prolapse down into the maxillary sinus, and that's purely because the orbital floor is the thinnest part of the orbit. So as you can see here on the right, the patient's right eye has been punched or attacked somehow, and they've got an orbital blowout fracture, so the globe has gone back, the pressure within the bony orbit is increased, and the thin orbital floor has blown, and they've got herniation into the maxillary sinus. So you can just appreciate the inferior rectus muscle has gone down into that gap. So if you see patients like this, the important thing that we think of as clinicians when referring patients is make sure that the eye itself isn't lacerated, make sure they can still see. Those are the important things. And they might have hyphema, which is blood pooling in the anterior chamber of the eye, so in front of the pupil and the iris, but obviously within the eyeball itself. And that's often quite painful, so they might complain about that. And they might also complain that they get double vision, particularly when looking up and in, because those inferior muscles are actually trapped within the fracture, so they can't pull the eye down. So when they look up and in, the other eye looks normally, and then this eye gets trapped, so they get double vision because their eyes aren't focusing together. I must admit, if someone's suspecting an orbital floor fracture, we tend to do a CT because they're very difficult to visualise on plain film. We can sometimes see a teardrop sign, which is a sort of a soft tissue mass in the roof of the maxillary sinus that looks like it's dropping down like a tear, and that can indicate there's been an orbital floor fracture, as you can see on the right here, again, the right eye. But often, again, this is going to go to surgery for repair, so we just go straight to a CT nowadays. You might also see clouding of the maxillary sinus. You might see an eyebrow sign, which is a very dark crescent in the superior aspect of the orbit, and that's just air from the maxillary sinus going into the orbit. And because air is dark on X-ray, we see it as this sort of dark eyebrow above the orbit. So if the tissue isn't trapped, the surgeons will tend to watch and wait and observe these. But in the case of this patient here, the tissue is trapped within the bone, so they'll go for an ORIF, i.e. they'll go for an open reduction internal fixation. So the surgeons will go in, again, cut through the skin, dissect down, and fix the bone with a plate. You will sense there's a theme with facial fractures, there's a lot of plating. Now, mid-face fractures, these are the very, very interesting ones. So I'm sure you're all aware of McGregor's lines, and these are lines that we look for symmetry on plain face radiographs, and any asymmetry in either line 1, 2 or 3 could suggest that there's been a fracture of the mid-face, along with the things we've talked about, air from the sinus escaping, or soft tissue edema, or something like that. I must admit, again, we tend to do CT more than we do X-rays for suspected facial trauma, but it's good to know them if you see one coming up and you're not suspecting something, but they've had a fall a few months ago and you see it, it's often something you might be able to pick up. So McGregor's line should be smooth and continuous across the face, and any step or any asymmetry should lead you to suspect that there might be a fracture or disruption somewhere. So the Lafore classification is probably the most widely used classification of the mid-face fractures, and I quite enjoy this because I just love the history behind it. So René Lafore was a French surgeon in the 19th and 20th century, and basically he came up with this classification of facial fractures by gathering 30 cadavers from somewhere in France and inflicting facial trauma on them by dropping cannonballs on their faces and hitting them with bats. And he'd then sort of take the heads, boil them to remove the soft tissues, and have a look at the bones. I'm not quite sure we'd get past ethical clearance doing that nowadays, but it's obviously been quite useful. So on the left we have a Lafore type 1 fracture, and this is a fracture between the maxilla and basically separating the body of the maxilla from the nasal septum. So it's a fracture of the superior maxilla. So this is known colloquially as a floating maxilla. The type 2 is a pyramidal fracture, so it goes to the maxilla and the hard palate, so it actually travels back through the face into the plane of this image, and you get sort of a pyramid shape fracture of the mid-face, and that's known as a floating palate. And then type 3 is where you also have a fracture through the zygomatic processes. So basically the whole of the midface is separated from the orbits and from the upper face, and that's known as a floating face. So finding some pictures, these are the plates that I was talking about. So you can see that sort of above the orbit we've got plates, and then we've also got some of these sort of almost wire beads that are sort of punctured into the bones to fix the facial fracture. So it's actually a Lefort type 1. So the ORIF disimpacts the fracture, and then they realign the jaw to make sure that they've got normal occlusion, so they can actually talk and chew and eat and do all the normal things that the jaw should do. And then they put these intermaxillary fixations with plates to stabilise the fracture through healing. These are temporary, they can come out, but it's one of those things that we just don't see often. So you might see it on a routine facial x-ray and think, what is that? And it's probably that they've had a fracture in the past and that it's well healed, so you can't tell from the patient they've had a fracture, but you can still see these plates are in for the healing. So for the Lefort type 2, it's the same sort of fixation, but they also put plate fixation on the infraorbital regions. And then for the Lefort type 3, it's the same again, but they also do frontozygomatic repair, frontonasal repair, and repair the zygomatic arch as well, to make sure that the face is not only, make sure the jaw is not including well, but the face is actually attached where it should be. Another common mid-face injury is a zygomatic complex fracture. Obviously you can have the tripod of the zygoma where it attaches for the cheekbone around the side, and these are fixed again with ORIF, and you can either go in from the side with the temporal approach, under the eye, or from within the orbit. So rather than going underneath the bony orbit, actually going in the bony orbit, then behind through the maxillary sinus. And yet again, it's fixed with plates. So this is image taken during surgery, and these are what the metal plates look like. So they're literally plates that ballast against the bone, then are screwed in to ensure that the bone is connected together. And then radiologically, you might see something like this. So this person's had a maxillary fixation and a zygomatic process fixation more laterally as well. So yeah, you might come across these when taking facial x-rays. Probably the commonest mid-face injury is a nasal fracture. As I'm sure everyone knows, the nose is quite soft out towards the front, so it's really, really easy to damage the soft, gristly part of the nose, and then that can also go towards fracturing the nasal bone or the ethmoid bone in the centre. This is important when they go to surgery because they might have a septal hematoma. So the midline of the nose is the septum, and if there's a hematoma there, it can obviously block the airway. And they're exceedingly common because the skin on the inside of the nasal mucosa it's one of the most vascular parts of the body, which is why people often, when they have nosebleeds, even if they're not on anticoagulants, they'll just keep bleeding, and then they'll stop and they'll sneeze and they'll start bleeding again, because it really is minor force that can cause this area to bleed. So if the nasal fracture is purely located to the nose, they'll go for a closed manipulation with packing in the splint, which is the image I've got here. So you can see that they splint the nose to make sure it's straight, centre the septum, pack both sides, and basically tamponade out the bleed. So they have nasal tampons which just soak up the blood and also cause a pressure from the inside to actually compress the vessels and stop them from bleeding. If the orbital rim is involved, then same as everything else, it's microplate reconstruction, and if they need a bone graft, they can take some bone from somewhere else, usually the hip or the pelvis from the back, and actually put in the patient's own bone to remodel the nasal architecture. So coming on to lower face fractures, mandible fractures, exceedingly common in bar fights and people being punched, as you can imagine. And again, these are fixed with plates and screws. So there's a picture here from a surgery, and you can see that basically you want to keep that angle of the mandible correct. So you would plate across and screw in the whole way. So that's the screws going in there, and then we put a plate across like this. And the reason for that is if the mandible heals together, similar to like if we leave forearm, so radius, ulnar, or humerus to heal by itself, they don't often quite heal how the bone was originally, which for your arm is fine if you have a slight angle or a slight notch, but for the mandible, because we want the jaw to occlude so the patient can eat, can talk, can do all those things, we really need to make sure that that mandibular arch is maintained, which is why we plate the whole thing to make sure it's actually maintained as it should be. The mandible also can dislocate. So this is where, again, a lateral face radiograph comes in useful. And you can see clearly here that the TMJ is completely dislocated and that the mandible is actually hanging quite low and quite anterior, and it's angulated quite forward as well. When reading about this, I was quite scared and shocked that one of the commonest causes of mandibular dislocation is yawning, which is absolutely horrifying. But also eating, dystonia, so drug reactions. If people have a seizure, this can come out, the mandible can dislocate, and also sometimes it happens when anaesthetists try to intubate people. They need to get some more space, they move the mandible, it dislocates. It can also happen following dental surgery. If people have wisdom teeth surgery, sometimes the surgeon will dislocate the jaw, and then that makes the TMJs lax and they're more likely to dislocate in the future. When you see them, you know they've dislocated their jaw because they're drooling, they've got pain where the TMJs should be, and the jaw is hanging on the floor like a cartoon character. So you really will notice it. And the way you put it back in, really simple. You put your fingers in, you trust the patient not to bite you. You put traction on the lower posterior molars, so you basically pull towards you, and then you sort of clip the jaw back into position, and you basically say to the patient, don't chew or yawn for 24 hours, don't do anything, don't go and sing opera, do something that's going to involve too much movement for 24 hours and let it settle. If patients present late, similar to shoulder dislocations, they'll be in muscle spasm and they'll need to be sedated. And then you have to be really careful because you want them to be sedated, but also you're manipulating their mouth. You worry about their airway, so you want to be really, really careful with them. But unlike shoulders, most people with jaw dislocations do tend to come very quickly and complain that something's wrong. So the final section is tooth injuries. So tooth injuries exist on a spectrum. So the first tooth injury would be a concussion, which is where there's pain of the tooth, but there's no loosening or displacement. And then similarly to joint injuries, where a joint can be subluxed when it's not fully out of joint, but it's also not in the correct anatomical position, teeth can be luxed. So subluxation is where there's pain, they are loose within the socket, but they've not actually been displaced. They can be extrusively luxated, where there's loosening and the tooth comes out of the socket slightly, as in the lower left image. They can be lateral luxated, where it doesn't go out but it moves to the side. And they can be intrusively luxated, which is where the tooth actually is impacted, goes the other way and is driven into the bone. So luxations are treated as the image on the bottom right shows, with a flexible splint going across the tooth and its neighbours to keep it in the correct position. So avulsions are complete removal of a tooth from the socket, as here you can see the lower left one tooth has been completely avulsed. It's no longer in the socket in the middle of the OPG there. So in order to reimplant the tooth and have a good chance at healing, the dry time should be less than 60 minutes. So it's really, really quick from tooth avulsion to getting to a maxillofacial surgeon or a dentist to actually reimplant the tooth. The tooth can be stored for transport and also for its own health. So the best place is stick it back in the socket. It will hurt, and people obviously don't like this, but the tooth has just come from the socket. That's where it needs to be. If you put it back in the socket, it has a nutrient-rich blood supply. That is the best place for it to be. If that's not possible, you can actually store it in the buccal sulcus, so between the lower gum and the cheek, and then you're at least keeping it in the patient's mouth, in saliva. It's got the nutrients that it needs, but it doesn't have that rich blood supply. Failing that, you can get your patient to spit into a little cup and keep it in their saliva, or milk is the next choice. So particularly for children, we might not trust them to keep it in the socket or in their mouth safely because they could swallow it or inhale it. So you might want to put it in a little cup of milk for transfer to the hospital to give the tooth the best chance of survival. So once the tooth is replanted, the laceration of the gum or the gingiva is sutured, and then they put a flexible splint on again as for luxations, and also root canal therapy because obviously the nerve has been severed, so that's not going to be viable anymore, but they can actually do a root canal and reimplant the tooth that way. So that's really everything I had to say. These are the references that I've used basically to build this presentation, some of the images and some of the information. Maxfax.co.uk is a fantastic resource for all things maxillofacial surgery, and it gives information at 3 levels, so you can kind of go on and see a brief overview, then go for a more in-depth conversation, then you can go on and view information at like quite a high academic level. Full disclosure, I do contribute to the website, so I am quite biased, but I do also think that the information there is quite good and quite useful. The Harrow Dental Practice was quite good for going over the nomenclature of teeth, and Geeky Medics was also good for going over the nomenclature of teeth, because it's something that's, to dentists, I'm sure it's so simple that there's not a lot of resources on it because they all know it, but for anyone that's not a dentist, you think, I've no idea what I'm looking at. And the paper below was just quite interesting. That's where I got the information on cone beam CT. So if anyone wants to read a bit more about how that works and the physics of it, it's quite a good read and it's quite interesting. I find it very useful, and that's where I got the image of the cone beam from as well. So thank you very much for listening to this. It's been very nice to teach you, and really, really odd to have this experience of teaching via video, not actually seeing people in a room, but I know that that's how things are going to move towards in the future. If you have any questions, please do either email me or email Steph, who will be distributing this for you. Please do give feedback, what was good, what was bad, what you found interesting. And yeah, if I do get any questions and anything that I think would be interesting to everyone, I'll email back and try and get some answers to something. But if not, I hope that was useful, and I hope you all have a great day, and thank you very much.